let's look at the mode of action of glucocorticoids. Now, glucocorticoids are very important for you to understand because they relate to almost everything. Every ward, every clinic you're going to go in will have some sort of glucocorticoids related to it, discussed in it, side effects. Something will have glucocorticoids in it, be it ophthal ward. You can go into the ophthalmology clinic, or you could go into any clinic in the hospital, and it will have some sort of glucocorticoids in it, and they'll ask you, how does this affect our particular system that we're talking about? How does this affect ophthalmology? How does this affect the eye? How does this affect the feet? I don't know what clinic you're in. If they're gonna talk about it, the doc's gonna ask you about it. It's important that you understand this. We have the same pathway once again. Calcineurin dephosphorylates NF-AT, activates NF-kappa B, activates inflammatory cytokines, IL-2, this is the IL-2R, right? This is the pathway. How do glucocorticoids relate to it? Well, glucocorticoids block nuclear factor kappa B as whole, inhibits the transcription of inflammatory cytokines. This is where glucocorticoids act. And that's not the only way. Glucocorticoids have many other mode of action, how they inhibit inflammation. And I'm going to talk about that. But firstly, you need to understand that glucocorticoids inhibit the transcription of nuclear factor kappa B, because that might be asked in your exams. You know this pathway now. At this point, you know this pathway. You know where sirolimus acts. You know where sirolimus acts. You know where basiliximab acts, and where all the seeds kind of get stuck. And you know where cyclosporine, our friend cyclosporine and tacrolimus acts. And you know where the glucocorticoids act. They act on the nuclear factor kappa B. They act on the important stuff, the big stuff. Right. What else do glucocorticoids do? How else do they inhibit inflammation? Or how else do they inhibit the proper inflammatory response or the immune response? Corticosteroids inhibit the first thing in this whole pathway. That's so cool. I mean, they're not bothering like aspirin and other NSAIDs do. They don't care whether it's cyclooxygenase, whether it's xylitol or the asthma drugs that we usually give. They don't care about anything. They just block the phospholipase A2 in whole. That's why we give inhaled corticosteroids for people with asthma, because we don't want this stuff to be made in the body. Or that's why we give aspirin and other NSAIDs in other conditions that we need platelet aggregation or prostacyclins. We want to inhibit those. So we give aspirin and other NSAIDs too. In all of those conditions, you can also use mostly corticosteroids. They're very important in the hospital. You need to remember corticosteroids. They're probably one of the like highly prescribed drugs that you'll see in the clinics. So what are the biochemical action? What are the biochemical, particularly anti-inflammatory or immunosuppressive actions of this corticosteroids? They decrease the phospholipase A2. Do you remember what was phospholipase A2? Or do you want me to show to you it again? Phospholipase A2 was this enzyme in the process of the formation of prostaglandins and also leukotrienes. Right? So it decreases the formation of phospholipase A2, and the activity of it leads to decreased leukotrienes, decreased prostaglandins. It also decreases the interleukin. How does it do that? It inhibits nuclear factor kappa B. It decreases the platelet activating factors and other factors that are important in inflammation. It decreases the leukocyte migration. It doesn't even let the white blood cell reach the site of the inflammation. It increases leukocyte stability, meaning it decreases the release of stuff by the leukocyte. If the leukocyte was ready to release these enzymes that it got, release these enzymes, right? So this membrane-bound vesicles that it has, that it was almost about to release here. So what the glucocorticoids do is that, no, buddy, you're not going to release these. We're going to increase the leukocyte stability. You're not going to phagocytose, and you're not going to receive, you're not going to release this extra stuff into the extracellular zone. It decreases the capillary permeability. So it not only inhibits the leukocyte from migrating, it inhibits even it from percolating the wall, from even going through the wall. So it decreases the capillary permeability. All of these actions are very, very important in decreasing inflammation, decreasing the immune response of the body, or suppressing the immune system. Very simple. neutrophilia. Neutrophilia is something that you will have to remember. But how does it do that? Due to decreased ICAM. So how neutrophils are they're usually bound to ICAM in sites of your body, particularly your lungs. So they're bound to ICAM. They're like hanging like bats from the roof. So they're like waiting. And what it does is that you do something that causes, like Batman has entered the Batcave, and it causes all of those bats to fly. So that's what it exactly does. The hooks to which the neutrophils are attached, it decreases those, causes increased level of neutrophil. But it also inhibits the action of these neutrophils. It's just increased, right? So the levels of neutrophils is increased, but they're not really acting because it is increased the leukocyte stability, decrease the leukocyte migration, decrease the capillary permeability. So it's inhibiting everything, just increasing their numbers. So this is a mnemonic that I want you to learn to understand glucocorticoids. This is a mnemonic that I made. There's also another mnemonic. I'll add a link. I'll try to add that in the description as well. So this is the mnemonic that I made to remember glucocorticoids and their extensive effects on the body. They have extensive effects on the body. By the GLR, you're going to remember glaucoma. By the GLR, you're going to remember glaucoma. Glucocorticoids cause glaucoma. How do they do that? They decrease the prostaglandins. What do prostaglandins do in the eye? They increase the drainage of the aqueous humor. I'm not going to talk about that in detail. I have a different video on anti-glaucoma drugs. I'll add a link if you want to see that. So what do glucocorticoids do? They cause glaucoma because they increase the pressure by decreasing the prostaglandins. Uco or gluco basically means sugar. So it causes hyperglycemia. Glucocorticoids cause hyperglycemia. You want to remember that. Believe me, you want to remember that. You want to learn this slide by heart because it's really important that you do. That is my advice to you as a senior, as someone who has seen the hospital. This slide is something you want to remember. Hyperglycemia or insulin resistance is something you want to remember. Glaucoma. Gluco is hyperglycemia or insulin resistance. Cortico. So what I've tried to make sure that you kind of act as a memory hook is that in glucocorticoids there's O 3 times. That's too many O's, right? That's too many O's. And what is another word that has too many O's? What are O? An O is a hole. So it makes holes in your bone. Not exactly, but that's what osteoporosis basically means, decrease in trabecular bone mass. So too many O's in glucocorticoids and same too many O's in osteoporosis. And that's how you're going to remember too many O's in your bones, too many O's in your bones or holes in your bones. That's what glucocorticoids does. It causes osteoporosis, decreases trabecular bone mass. How does it do that? It decreases the action of the osteoblasts, increases the action of the osteoclasts. It increases rank L and monocyte colony cell stimulating factor. You're gonna want to remember this pathway. This is how osteoprotegenin and how I'm not going to talk about this, but just remember it increases rank L and it increases rank L and also causes MCSF formation, right? It increases MCSF formation, which leads to increased osteoclasts. Monocytes are basically osteoclasts are activated monocytes. So by N, you're going to remember infections. By N, you're going to remember infections. Infections like candidal thrush, something that you want to remember, right? So by cortico, I have tried to say that you can remember cataracts, but if you remember glaucoma, one of the other things, posterior capsular cataracts, that's a lot of C, right? And what else is the word that has a lot of CO or C in it is glucocorticoids. It has C I think 3 times at least. Glucocorticoids has C 3 times and cataracts has C 2 times at least. So that's how you're going to remember that glucocorticoids cause posterior. If you just remember the sentence, glucocorticoid cause posterior subcapsular cataracts. That's a lot of C's. That's how you're going to remember glucocorticoids cause cataracts. Wonderland. Wunderland. You can also say glucocorticoids in Wunderland because they decrease the wound healing. ER. What are we remembering by ER? You're remembering water retention, or WATER. Basically, it's absurd, but it's going to help you remember. Believe me, it's going to help you remember. Because if you study endocrinology a bit, you're gonna understand how fludrocortisone and these drugs are used for water retention, right? So it causes water retention, water or sodium retention, which can cause edema, hypertension, hypokalemic alkalosis. I'm not going to talk about the details, but just know the ER or water or wonder, however you're going to remember it, just know it also causes water or sodium retention. And there are actually some corticosteroids that are actually used for water replacement, like fludrocortisone. So this is how you're going to remember fludrocortisone, and this is a very, very good picture by Osmosis, which is a resource that I commonly use to study for these videos as well. So glucocorticoids in Wonderland, and this is a picture to show the common, and this is something that you will have in your clinical vignettes: moon face, buffalo hump, and all of these other things. I want you to at least pause and look at this photo at least once. Okay, so let us talk about the last two drugs that we have to study in immunosuppressants. The first one is Azathioprine and the other one is Mycophenolate. I'm not even going to try to say the second name, Mycophenolate, mofetil or something. Anyways, so both of these drugs act on the de novo pathway of the synthesis of purines. De novo means new, pathway is just pathway, synthesis means formation. So the de novo or the new formation of purines, there are actually two pathways. There's one, the salvage pathway. Salvage means that something is being destroyed. We actually take the pieces of some of those purines and make new ones. And de novo pathway is actually the new formation of purines. So what happens is, what's the component of a purine? Purine are basically bases that are added to form a nucleotide. So this is a ribose 5-phosphate. Ribose 5-phosphate is changed into PRPP. PRPP is then changed by an enzyme known as PRPP amidotransferase into IMP or inosine monophosphate, and which is converted by an enzyme known as IMP dehydrogenase into GMP or guanosine monophosphate and AMP. These are the steps, just these are the steps that you have to remember for this pharmacology in particular. This is the really high yield stuff that you have to remember. When you're going to study biochemistry, you're going to see a huge pathway with a lot of enzymes. If you want to remember the drugs only, just remember this. Ribose 5-phosphate is converted into PRPP. PRPP is converted into IMP. Where does Azathioprine act? Where does Mycophenolate mofetil act? And why is this important? Which is then used to formation of DNA and RNA. Mycophenolate mofetil acts on IMPD or IMP dehydrogenase. What does IMP dehydrogenase do? It dehydrogenates, meaning it removes the hydrogen from IMP and forms GMP or guanosine monophosphate. What else does it do? Where does Azathioprine or 6-MP or 6-mercaptopurine act? What is 6-mercaptopurine? 6-mercaptopurine is the product of Azathioprine. So Azathioprine is converted into 6-mercaptopurine, which then acts on a different pathway. So basically, Azathioprine and 6-mercaptopurine block PRPP amidotransferase. What does that do? It converts PRPP to IMP, and also the usage of AMP in DNA and RNA. That is what Azathioprine or 6-mercaptopurine, which is just the product of Azathioprine, it does. What does Mycophenolate? Let's look at this slide again. So ribose 5-phosphate is converted into PRPP by PRPP amidotransferase. IMP is converted into GMP by IMPD. IMPD is inhibited by Mycophenolate, and PRPP amidotransferase is inhibited by Azathioprine, and it inhibits the incorporation of AMP in DNA and RNA. Now you need to remember the drug side effects of both of these medications, which is a very interesting side effect of Mycophenolate mofetil is that it causes a CMV infection. It can predispose the person to developing an invasive CMV infection. That is very specific. This is a very specific side effect that you have to remember. CMV means cytomegalovirus. Mycophenolate mofetil, so many M's. There are two M's in Mycophenolate mofetil, and there's an M right in the middle. So M is very important in remembering Mycophenolate mofetil or mofetil. I don't know if I'm pronouncing it right or wrong. And M is very important in CMV. It's right in the middle. Both have M's. Mycophenolate, CMV. and azathioprine, pancytopenia. Pancytopenia is an important side effect of both of these medications. Both of these medications, when taken in toxic doses, can cause pancytopenia. Why do you think so? Both of these drugs are causing inhibition of the formation of DNA and RNA. Obviously, they'll cause pancytopenia. If you inhibit the formation of DNA and RNA, obviously you're going to cause decreased all cell lines. You're decreasing all cell lines. All cell lines, what do they have in common? They have DNA and RNA, of course, except red blood cells. But still, even in red blood cells, you have some DNA and then that is excluded out. So basically, if you decrease most medications that decrease chemotherapy, immunosuppressants that decrease the formation, that act on DNA, that inhibit mitosis, most all cause pancytopenia. Both of these drugs cause pancytopenia. Something else that you have to remember is that azathioprine is a bit less nephro and neurotoxic. It's a bit less nephro and neurotoxic. Now, I'm going to tell you something really, really cool, something that will get tested in your exams, which is the interaction between azathioprine and allopurinol. Now, how are these two drugs linked, you might ask? Now, you might know that allopurinol inhibits the enzyme known as xanthine oxidase. It inhibits the enzyme known as xanthine oxidase. So what azathioprine does is, azathioprine is converted into 6-MP. This is the metabolism pathway of azathioprine. Azathioprine is converted into 6-MP. 6-MP is converted by 8-GPRT, and then this, whatever the product is, it inhibits cellular proliferation. How does it do that? We just remembered a while ago that it inhibits PRPP aminotransferase, and it also inhibits the incorporation of AMP into cellular DNA or RNA. So azathioprine inhibits cellular proliferation, but how is it metabolized? It's metabolized by something known as TPMT. I don't even know what that stands for. You can search it up, you can Google it. I'm not going to Google it right now. And xanthine oxidase. Both of these pathways are important in the metabolism of azathioprine, and both of these enzymes, I've mentioned them here because both of these enzymes are clinically relevant, clinically important for you to know. Xanthine oxidase and TPMT convert 6-MP into inactive metabolites. What's the clinical correlate for xanthine oxidase? What do you do when you take allopurinol? You inhibit xanthine oxidase. You inhibit xanthine oxidase. Sorry, that should have been the other way around. So you inhibit xanthine oxidase. What do you do when you inhibit xanthine oxidase? You're going to increase the levels of azathioprine. If you increase the level of azathioprine, what do? You cause pancytopenia. I just told you toxic doses of both mycophenolate and azathioprine cause pancytopenia. What do you do when you have less levels of TPMT? Well, about 12% people, 12%, that's actually a lot. That's 1 in 10, almost 1 in 10, more than 1 in 10. More than 12% of people are deficient in TPMT. So if you take in allopurinol, or if you are someone in the 12% who has decreased level of TPMT, you are prone to developing high levels of azathioprine. And what will that do? That will cause pancytopenia because it causes decreased cellular proliferation, pancytopenia. Very important clinical correlate. You need to remember this. Now, let us revise everything. Cyclosporin and tacrolimus, we remember these. These are both calcineurin inhibitors. And how do we remember the mnemonics? Hairy kidney on a bicycle, meaning it has nephrotoxicity, it has hypertension, it has hyperlipidemia, and the other mnemonic was tic-tac binds FKBP, which is a very brainy thing to remember, and it causes neurotoxicity. You remember that, right? What do we have for sirolimus? Sirolimus is an IL-2R inhibitor. Sirolimus is an IL-2R inhibitor. Finally, let us look at the summary of things, right? So cyclosporin and tacrolimus are both calcineurin inhibitors. I went through the diagram many times for you to know this at this point. Cyclosporin and tacrolimus are calcineurin inhibitors. Hairy kidney on a bicycle was the mnemonic. Hairy means hyperplasia of those hirsutism, gingival hyperplasia, hypertension,
because the kidney is riding the bicycle, so it gets all riled up, has hypertension, hyperlipidemia, and nephrotoxicity because it's a kidney. We have Tic Tac binds FKBP, which is a brainy thing to remember. Only smart people can remember it, so it causes nephrotoxicity. Sirolimus is an mTOR inhibitor, causes pancytopenia, hyperlipidemia, hyperglycemia. You remember the mnemonic. I drew a picture for you where sirolimus is stabbing the RBCs, but it's not stabbing the kidney, so it's not nephrotoxic. Glucocorticoids made a detailed mnemonic about this. Glucocorticoids in Wonderland, where GL or GL means hyperglycemia, glaucoma, or ulcers, and 3 O's in glucocorticoids mean osteoporosis. Glucocataracts is something that you can remember. There's too many C's, or corticoids, cataracts sound very similar. Wonder means wound healing is impaired. In means infections, and Wonderland, you can have water retention, edema, and hypertension. Basiliximab or basil seeds, which are blocking the IL-2 receptor. Blocking the IL-2 receptor causes edema, hypertension, tremor. These are the possible side effects. Azathioprine inhibits PRPP amidotransferase, also inhibits the incorporation of AMP into DNA, causes GI upset or pancytopenia in toxic doses. Mycophenolate mofetil, an important indication I forgot to mention here is allopurinol. The interaction of allopurinol, interaction causes upregulation of azathioprine, which causes pancytopenia. Why? Because it inhibits xanthine oxidase. You know that. Mycophenolate mofetil inhibits IMP dehydrogenase, can cause pancytopenia just like azathioprine, predisposes the person towards developing the CMV infection. Now you know everything there is about immunosuppressants. Thank you so much for watching this video, and thank you so much for your love and support. Our channel just hit 1,000 subscribers. Please like and share my videos and let me know what you want the next video to be on. Thank you so much.